Thank you very much, Erin, and really nice to be here. Really happy to have this opportunity to share with you some of our experience in testing, genetic testing and screening for families with pancreatic cancer. And I really liked hearing where everyone is from, so it gives me a better idea that we're not just a Canadian audience. A lot of what I'll speak to is a bit more in a Canadian context, but I actually think it applies really regardless of where we live. So with that, I'll just mention that I do work at BC Cancer. We have a hereditary cancer program, and many provinces in Canada will also have a hereditary cancer program where there's some specialization in genetic testing, and I'll talk a bit about how to find your local genetics clinic later on in the presentation. So I am in Vancouver, Canada, and just acknowledging that I work on the unceded and traditional ancestral territories of the Coast Salish peoples. So my plan for today is to talk about, what are the hereditary and familial forms of pancreatic cancer? And I'd like us to talk a bit about, who should consider screening and who should consider genetic testing. Maybe some of you are already on those paths or have completed those tests. And I'm also happy to hear from you during the presentation if you have questions. Erin was kind enough to send me a few questions ahead of time. So I will hope to address those during the talk today. So just showing here, of course, the pancreas with these two really critical functions in our body, which is for digestion and also for blood sugar regulation. You can see the head, the body, and the tail of the pancreas here. We'll talk a little bit about screening and how screening is done to look for pancreatic cancers at the earliest possible stage. But this is just giving us a little bit of the lay of the land here. Most of what I'll talk about today is the type of pancreatic cancer that affects the exocrine part of the pancreas. So we talked about those two main functions of the pancreas, the kind of digestive function, and then more of that regulation of blood sugar function. So the exocrine function is that kind of function with the digestion, enzymes. This is really, the process where bile helps us to break down fats and food. And the cancer that we see that affects the exocrine part of the pancreas is called pancreatic ductal adenocarcinoma. And that's the most common type. 90% of pancreatic cancer is in this part of the pancreas, affecting the exocrine cells. But then we have another type of pancreatic cancer that's quite different in terms of causes, treatment, genetics, et cetera. And that's the endocrine type of pancreatic cancer called PNET, or pancreatic neuroendocrine tumors. And those affect the cells that are responsible for kind of glucose monitoring levels, and in particular called the islets of Langerhans cells. So I will focus a little bit more on this exocrine type of pancreatic cancer today, especially because risk factors are the key to be aware of for most people who are concerned about pancreatic cancer. And we know the risk factors for pancreatic ductal cancer are mainly age, smoking, diabetes, a type of inflammation of the pancreatic tissue called pancreatitis, which can be chronic or even hereditary in some families, happening at really young ages. Ethnicity is a risk factor, with pancreatic cancer seeming to affect African Americans at a higher frequency than individuals of European ancestry. And then for some individuals, having a precursor lesion in the pancreas, such as an IPMN or an MCN, so those stand for intraductal papillary mucinous neoplasm or a mucinous cystic neoplasm. So these are kind of tumors or cysts identified in the pancreas through screening. Those individuals may have an increased risk. And I've listed a few other risk factors. Gender, interestingly, slightly higher risk for men compared to women, but it's not a huge difference. And if you looked at Canadians overall, our chances of developing pancreatic cancer are 1 in 75. So that's the same thing as saying we have a 1.3% risk over our lifetime to develop pancreatic cancer. Alcohol and obesity, risk factors that might bump our risk up a bit above the average, just as the other risk factors here that you see listed. Today, I'm going to mainly focus on family history as a risk factor because that's what we focus in on in our program. So this is a slide based on a recent study that asked that question: what is the chance of developing pancreatic cancer if we have a family history? And I'll just point out this first line here. This is if we did not have any relatives with pancreatic cancer. But in the most recent American data on epidemiology of cancer, we've seen a slight increase in the lifetime risk of pancreatic cancer. It's bumped up a little bit over the past few years. And we now, at least in the US, the estimate is a 1.7% lifetime risk for pancreatic cancer. So a bit higher than what I showed you with the Canadian most recent estimates. If somebody has one close relative, we call it a first-degree relative, which would be a parent, sibling, or child, the risk is a little bit higher than average, and it's estimated to be about 3%, and that's a range, so it could be anywhere between 2 and 5%. If that relative was diagnosed at a younger age, that seems to have an influence in the risk. So the risk may be slightly higher. Here you can see 5%. For individuals who had a close relative diagnosed with pancreatic cancer under the age of 50. But that range could be anywhere between 2 and 7%. So these are estimates based on studies in large numbers of families. And I think the key message to show here is that the more relatives we have with pancreatic cancer, the more it affects our risk for developing pancreatic cancer compared to average. And these are risks up until the age of 75. I think the other thing that you're probably all thinking as well is that our family history doesn't act in of itself, by itself. It's in the context of our lifestyle, whether we're smokers, whether we have diabetes, our lifestyle. And so we don't have a good way of giving a personalized individual risk to a single person. We're often working with these kind of ranges or estimates that are really based on other pieces of data rather than a personal risk. Although we're getting there a little bit with genetic testing and personalized genetic risk assessment, but this is just based on family history alone. And then there are some families where there's really not a strong history of pancreatic cancer in any close relatives or even distant relatives. There might just be one case in the family and no other known history. And those individuals who might just have that one close relative are probably at a lower risk. And estimates are saying around 3% lifetime risk, anywhere between 1 and 4% would be the range. And if that person was diagnosed under 50, again, we see a little bit more of an increased risk there. And so this is for families where there's really not a strong history. So hereditary pancreatic cancer is where we believe there is a strong single genetic predisposition that's being passed down through the generations that might have a more substantial effect on our risk. So when we think about hereditary pancreatic cancer, think about a major gene that's adding additional risk. But we also know there's something called familial pancreatic cancer. And I'm going to explain these little jars that I've put up here. So these jars represent risk. And if these jars are filled up over our lifetime, that might be enough to result in a cancer developing. Some of our risk factors are genetic. We've colored those orange in this picture. And of course, some of our risk factors are environmental, age, lifestyle, diet, etc. Some of the genetic risk factors are large ones, and some of them might be very small genetic risk factors that might only increase our risk a little bit. So in this hereditary category, you see that large genetic risk factor has actually accounted or contributed to a lot of the risk for that individual, and they may only need a few additional risk factors in order for cancer to develop. Whereas in familial pancreatic cancer, we're not able to find one single major genetic cause for the cancers that seem to be clustering in that family. But we do think that there's a shared susceptibility there, probably partly genetic and partly environmental or non-genetic. And in those families, we would consider them to have familial pancreatic cancer if we can't quite find one major hereditary risk. Whereas we'd call a family hereditary if we are able to find that genetic risk factor that causes a large part of the risk. And finally, most pancreatic cancer, as you can see here in this dark blue section, is not due to inherited genetic risk factors. And most of the time, pancreatic cancer happens because of those environmental, age-related risk factors that we all face during our lifetime. I added a little note here just for us to remember that familial, usually we're using that only when there are two close relatives of pancreatic cancer in a family. Hereditary, when there's that gene mutation. I'm going to back up for a second. Now I'm going to go forward again. A big move or change in our thinking about how to test for hereditary cancer of the pancreas happened in 2019. So that's coming up to 4 years ago, I guess. And in 2019, a really big guideline kind of consortium group called the National Comprehensive Cancer Network, or NCCN, started to recommend that all patients with pancreatic cancer have hereditary genetic testing. And the reason why they recommended that is because we realized that family history wasn't always helping us to find the pancreatic cancer patients that fell into that major hereditary category versus the familial category versus the sporadic category. In other words, the family tree or the age at diagnosis wasn't really sensitive. It wasn't helping us to determine who should get genetic testing and who shouldn't. We were finding people with hereditary pancreatic cancers, even who didn't have a strong family history of other relatives with pancreatic cancer. And so we wanted to switch gears and start being more flexible and broader with who should be offered genetic testing. 1 in every 10 patients with pancreatic cancer will have a hereditary finding. So that's a 10% likelihood that we'll find some helpful genetic risk factor there. And this can have treatment implications for the patient in terms of what they plan with their oncologist, and it also can have implications for their family members, siblings and children potentially. So what are those hereditary findings? This is a slide that just lists, underneath this hereditary pancreatic cancer genes, that we have now 11 or 12 genes that have been identified that actually protect us from pancreatic cancer. That's their job in the body. They also protect us from other cancers. And if there's a problem in any of those genes, what we call a mutation in the gene or a pathogenic variant is the scientific term for that, if that gene is not working properly due to a genetic alteration or a mutation, it causes us to have an increased risk for pancreatic cancer over the course of our lifetime. So each of these genes is associated with specific types of cancer. Most of these genes are related to cancers that would develop in adults, not in children. And not everyone who has a problem in one of these genes will develop cancer. So these are called hereditary cancer susceptibility syndromes, which is really important to distinguish from a condition where we know the kind of these are not conditions where we can predict what will happen. We have learned a lot in the past 4 years after doing so much testing for patients with pancreatic cancer, what each of these gene risks would cause in terms of the cancer risk. And the top gene there, you see ATM. And we believe that that risk would be somewhere in the range of 5 to 10% for somebody to be born with that gene and to develop pancreatic cancer. So keep that in mind when you're thinking about what was that background risk. So with that recent US data on their population SEER database, the average person had a 1.7% risk of developing pancreatic cancer over their lifetime. So you can see that having an ATM genetic risk factor puts us at a significantly higher risk. And the same for these other genes that you see listed here. You know, each of these genes has characteristics. They're associated with particular types of increased cancer risks. And genetic testing, if it did reveal any of these genes, there'd be a specific set of guidelines to follow. And what I might do is actually just give an example next of some specific cases. I'll just check in with you, Erin, if there was any questions in the chat or anything that that had come up for me to address yet.
Yeah, there's nothing yet in the chat. Yeah, but I will keep you posted.
Sounds perfect. So this is just one example of a syndrome that can cause an increased risk for pancreatic cancer in the range of about a 5% lifetime risk. And there are important management implications if we find this hereditary cancer susceptibility syndrome for somebody. The first is that this increases our risk for breast cancer and ovarian and prostate cancer, in addition to pancreatic cancer. So there are ways to manage those risks by offering women breast MRI starting at 25 and annual mammograms starting at age 30. And some women with these hereditary cancer mutations called BRCA1 and BRCA2 or BRCA1 and BRCA2 genes, they may consider preventative surgery to reduce the risk of ever developing breast cancer because the risk is significantly higher than average. Ovarian cancer can be managed with preventative surgery for these BRCA1 and BRCA2 patients. Birth control pill can be effective at reducing the risk as well. For men with a mutation in these two genes, they're recommended to start prostate cancer screening at 40. And of course, pancreatic screening, which we're going to talk about today, for BRCA1 and BRCA2, it kind of depends on the family history. Most guidelines suggest that that risk is probably only warranting screening if we have a family history of pancreatic cancer. But we're still learning lots about who the best people are to offer screening for. Lynch syndrome is another example due to mutations in MLH1, MSH2, PMS2, and MSH6. But this is a condition that causes an increased risk for pancreatic as well as some other GI cancers, mainly colon cancer. For women, there's a strong increased risk for uterine and ovarian cancer. So there'd be a different set of guidelines to follow if somebody found out that they had this hereditary cancer susceptibility syndrome. And it mainly focuses on colonoscopy to catch any colon cancers early when they're a polyp or an early stage colon cancer. And there's been good success in preventing cancers for people with Lynch syndrome and for people with hereditary breast and ovarian cancer syndrome because of these management guidelines. For pancreatic cancer, if we find out we have a particular hereditary form of that disease, that can help your oncologist or a patient's oncologist make some decisions about treatment. Probably one of the biggest kind of exciting developments was with a drug called a PARP inhibitor, which can be quite effective in patients with pancreatic cancer who have a BRCA1 or BRCA2 mutation, who have metastatic pancreatic cancer, and who then can be treated with this ongoing drug to help reduce the chance of relapse. In another situation, for patients who might have a metastatic or a locally advanced disease who are trying to choose types of chemotherapy, knowing about a BRCA1 or 2 mutation or a PALB2 mutation can help in deciding what chemotherapy options to pursue. Patients with hereditary pancreatic cancer seem to have more sensitivity and respond more to something called a platinum-based chemotherapy. And those are discussions that an oncologist would discuss with a patient when they get their hereditary results back. Oopsie. So I wanted to spend a moment next talking about prevention. So for family members, if we find out that there is a hereditary form of pancreatic cancer in the family, or a hereditary susceptibility to other cancers, this might help relatives to access earlier testing or more frequent testing, possibly medications for treatment, lifestyle changes or surgery, kind of those examples we talked about for those two syndromes that I used. And a genetic counselor would help a patient walk through those options and try to find a suitable path to manage those risks. So pancreatic cancer screening, this is a really big topic, and there is a lot of hope that we will develop in time better tools to detect pancreatic cancer at an earlier stage. Currently, pancreatic cancer is often detected, 80% of the time, at a stage that is too advanced to permit for surgery or a resection of that tumor. And we definitely need improvements in this area. Even in a population at increased risk for pancreatic cancer, there is a lot of interest in trying to identify what is the best tool to offer those individuals. We know that pancreatic cancer, because it's generally rare, 1.3, 1.7% lifetime risk, it's not recommended for the average risk person to undergo imaging of the pancreas because there would be too many false positives and the risks would outweigh benefits with the current techniques that we have. We need a lot more evidence about risks and benefits for the imaging that we have. And there isn't yet a simple blood test that can effectively find pancreatic cancer at an early stage. So what groups are proposing is taking certainly individuals in the general population who might have an increased risk, either because they have a family history or, and certainly offering those individuals germline hereditary testing, and then finding individuals who have that increased risk, so at least 5% or more over their lifetime would be considered kind of a range where pancreatic cancer screening, the benefits could outweigh some of the drawbacks. And then looking at those imaging options, which are, I'll go into in the next slide, EUS, which stands for endoscopic ultrasound, or MRI, essentially a type of magnetic resonance imaging of the pancreas. And then trying to sort out what are the useful clues to be looking for on those imaging tests, what experts call worrisome features, and how sensitive are those for helping a pancreatic cancer screening specialist advise the patient on what to do about those lesions. So there's lots of research in this area in order to improve the sensitivity of pancreatic cancer screening. So this is just a picture showing endoscopic ultrasound and MRI. Ideally, these should be performed in really experienced clinics, and ideally as part of research programs where you could track the outcomes. And that's because there are still quite a few questions about, the ideal frequency of the screening, what to do when different lesions are detected. So you certainly want to be followed in a center with expertise. In particular, an endoscopic ultrasound, this is where sound waves are used to create images of the pancreas that are viewed on a computer monitor. So I've tried to find a picture there. In this test, it's an echo endoscope, which is that thin tube you see there inserted. And it's attached to an ultrasound probe. It's placed in the person's mouth and advanced with sedation into the small intestine where the pancreas can be viewed. So a really specialized test that should really be done by individuals with experience in pancreatic screening. Of course, the MRI can be a magnetic resonance cholangiopancreatography, which is even a more specialized form of using magnetic fields and radio waves to produce this kind of three-dimensional detailed view of the pancreas and the bile ducts. And these are usually performed in an enclosed machine, which you see there. So Who should consider it? Pancreatic cancer screening. We've talked a little bit about, these hereditary scenarios, these familial scenarios where there's maybe multiple genetic factors. And then we've talked about sporadic pancreatic cancer, which most pancreatic cancer falls into that category. And for those family members, there probably isn't a significantly increased risk. But it should be considered if you are from a family that has this familial form of pancreatic cancer. So, 2 or more close relatives, and you yourself have a close relative, like a parent, child, or sibling. It should also be considered if you have a hereditary risk factor after doing genetic testing, let's say, and if you have a close relative with pancreatic cancer, we feel like this is a group that consensus guidelines are saying, yes, screening should be considered in that group. There are some genes, and I've mentioned 2 of them there, CDKN2A and STK11, where the risk for pancreatic cancer is much higher. And even if somebody had no family history of pancreatic cancer, we feel that pancreatic screening could be of benefit because that risk range is significantly higher than that 1.7% background risk. Usually screening starts at 50. It's very rarely recommended to begin before that age. A couple of exceptions would be if you have very young pancreatic cancer in the family, so a relative with pancreatic cancer at 45 or 50. And for some genes like CDKN2A and STK11, we might recommend starting a bit earlier if your genetic test showed a problem with one of those genes. Really important to have a good discussion about pros and cons with a GI specialist. And again, that note about doing this with an experienced physician and a multidisciplinary team to discuss kind of those imaging findings. So then what about genetic testing? Who should consider that? If it's going to help people identify their risk or understand their risk, could it not be a useful tool for everyone? I'm a bit biased because I'm a genetic counselor. And I do think that hereditary genetic testing is beneficial for many individuals. I think it's ideal if it can start in a relative who's had that pancreatic cancer, because that's helping us to figure out, was the pancreatic cancer sporadic? Was it maybe familial and just there's a strong family history, but we can't pinpoint a major genetic marker? Or was there a specific gene, BRCA1, MSH2, CDKN2A, those genes that I've talked about, was there a specific hereditary marker that has specific implications for relatives? So that's the best way to kind of approach it. And most patients with pancreatic cancer can access funded genetic testing through a genetics clinic in Canada. And that really helps clarify things for relatives. If our relative with pancreatic cancer has not had any testing or has passed away and it was never offered to them, then we don't know. We don't know the hereditary status. We don't know the cause. And it's still important for close relatives to consider genetic testing, because if it had fallen in that category, that hereditary category, that 10% chance it could have been hereditary, again, that has really important implications for prevention, management, for relatives. So in some provinces, unaffected relatives without cancer who have a close relative with pancreatic cancer might be offered funded testing. In BC, we recently started offering testing to any relatives who have a close person in their family with pancreatic cancer. In other situations, self-pay options are available. So mostly based on the United States, there are some, very highly performing medical grade commercial labs that offer affordable genetic testing for a panel of genes. Remember, pancreatic cancer isn't just one gene. We should really look at that, list of 10 to 12, hereditary pancreatic cancer genes. And some of those tests are in the range of $300 US. They can be done on a saliva sample. Family physicians can organize it. Some of these commercial labs will organize it for the patient as a patient request or patient-initiated test. So how would we do that? I think, first of all, a key takeaway is find your local genetics clinic. So if you have pancreatic cancer or you know somebody who has it, definitely make sure to get a referral to a local genetics clinic. In Canada, you can find clinics through this website. And in the United States, you can find clinics through the nsgc.org, so National Society for Genetic Counselors.org. And likely funded testing would take place for that patient. If you don't have pancreatic cancer, same thing. You've got a close relative or you're concerned about it, you could find your local genetics clinic, ask for a referral from your doctor, and speak to a genetic counselor. Or you could also look into commercial genetic testing labs. It's important that if a patient does that, to make sure it's a medical grade test, it's a multi-gene panel. Those are kind of some of the things you keep hearing me talk about. And it does require a requisition to be submitted. So usually that's from your physician. You can picture these little saliva kits that are getting mailed out. They usually have return shipping available. And then a patient would be contacted by that company for payment. And then a lab report would be issued with your result. This is not the same as ancestry-based testing, what sometimes we call recreational genetic testing. So very different from, say, 23andMe or Ancestry.ca. A medical grade test is specifically looking at these particular hereditary cancer genes and looking for any mistakes in any of these genes, and is a highly sensitive test for hereditary cancer. So let's say somebody went ahead, maybe some of you already have, with genetic testing. Just wanted to show here that there are 3 kinds of results we can get back. Most of the time, of course, it would be a negative result because hereditary cancer risk is not common. So usually we're talking about a negative result, which is right in the middle there. In those cases, we haven't explained the family history for pancreatic cancer. We probably would still be making recommendations for a patient based on what kind of cancers are in their family. It certainly does not mean that there's no risk for cancer. Cancer is still a common disease made up of many different diseases. And so it's important to look at your family history. If there was a mutation identified, we'd call that a positive result. And that's where we've got some useful information to actually make targeted recommendations based on that gene result. And it also means that genetic testing would be available to your family. A result that we can have is called an uncertain or an unknown significance result. That's when there's a variant found or a difference found in the genetic code, but we really don't know yet if it has any impact on our cancer risks, and more research is needed. I usually tell my patients that we don't get too worried about variants of unknown or uncertain significance because most of those will get reclassified to a harmless change in our genetic code. But I still want my patients to know if we found one, because I would like for us to be able to rule that out one day and with future research to say, you know what, this actually is not a risk factor. And in a very small number of cases, we might learn that it is a helpful risk factor, and that more testing or screening should be offered. So it's important to kind of stay tuned or stay connected with your genetics clinic if you have a variant of uncertain significance. And at this point, before I talk about the just inheritance pattern, maybe I'll just check in with you, Erin, or anybody here with questions that might have popped in your minds.
Yeah, so there's been a couple of questions in the chat. Are we born with a gene mutation, or can a mutation develop over time?
Such a great question. So cancer is a genetic disease, just by definition. It's affecting our DNA in our cells, our genetic code, but usually it's an acquired genetic disease. So these genetic mutations are accumulated over our lifetime in our body cells. And in some ways, this is just a feature of aging. And so cancer is in that way genetic. But very rarely, and I shouldn't say very rarely, 10% is not rare. In 10% of cases, that cancer was driven by an inherited genetic change. So in that situation, the person was born with that genetic mutation or risk factor, and they inherited it from the generations before them. And so that is really the difference between a hereditary form of cancer and a sporadic form. In the hereditary form, we started out with a genetic mutation that filled up our risk from the beginning, that risk jar. But in the sporadic or non-hereditary cancer, we've accumulated those genetic mutations over time with age over many, many years. One of the benefits of genetic testing is it can tell us whether we were born with an increased hereditary risk for specific types of cancer. And that's absolutely true. So if a person had a strong family history of pancreatic cancer and they decided, I want to find out if I might have inherited one of these hereditary risk factors, and if they did learn that they had, let's say, a BRCA1 or 2 mutation, then we do know that their risk for pancreatic cancer is increased. And depending on what gene it is, the risk might only be mildly higher than that background risk, or moderately higher, or it could be significantly higher than average. And depending on what gene that is, there might be other cancers that healthy individual should be undergoing more screening for. And so absolutely in that scenario, genetic testing, if it showed a hereditary risk factor, it would influence what your risks are for cancer and what the recommendations are in terms of how to manage those risks. Yeah, so great question. And it's kind of specific to one jurisdiction of Ontario and what the criteria are, which I'm probably not the best person to speak to, but I would say it's very likely that with that level of family history, that it would be funded. I like to tell patients about that self-pay option just in case they go to speak to their genetics clinic and they find out they're not eligible. I'd like patients to know that there are other options outside of a provincially funded test that would be equally good in terms of the type of genetic test you can obtain, because these are medical grade companies. But certainly for BC, we would definitely be offering testing to somebody who had a strong family history of pancreatic cancer. And, just starting last year, 2022, we started to offer testing to individuals who have one close relative, parent, sibling, or child with pancreatic cancer. If we didn't test that pancreatic cancer patient, so if we don't know if that pancreatic cancer patient had a hereditary type, we want to be able to offer the testing to their close relatives. And we're going to study that, testing criteria over time to see, is it helpful? Are we finding many hereditary cases? How useful is it? But that just gives you an idea that different provinces are moving forward in different stages with this. And I think you're right on to want to go and talk to that local clinic about what you might be covered for. And if you're not, to certainly look into options for yourself with commercial testing. So maybe I'll just highlight this slide only briefly because it gets to that question, which is that whole difference between the hereditary and the non-hereditary types of cancer. Well, non-hereditary cancers that we accumulate genetic mutations over our age and as we grow older, those are mutations that we can't pass down. But in the hereditary form of cancer, where we started with a major risk factor, it's present in all of the cells of our body. We were born with it. And when we make our egg and sperm cells, there is a 50% chance of passing that hereditary mutation down to each child. And the reason for that is we have 2 copies of every gene, one from mom and one from dad, but we only pass down one of those 2 copies in each egg cell we make or each sperm cell we make. So if we do have a hereditary risk factor in one of these genes, we don't usually see people with 2 mutations that are born with no good copy of a gene. So that's a very different scenario. In the vast majority of cases, we're dealing with somebody who has a mutated copy and a normal copy, and they have this hereditary susceptibility. And there's a 50% chance they pass down the normal copy to each child. That child does not inherit the increased risk. And there's a 50% chance that they pass down that hereditary risk factor. So for that person, they would be offered increased screening for those particular cancer risks when they get older. I think we kind of covered some of the benefits and of genetic testing. As a genetic counselor, I've seen all kinds of benefits described. Certainly helping people learn more about the risks for cancer, feeling more empowered, maybe decreasing some of the stress and worry for them if they find out they don't carry a hereditary risk factor, or helping them access the right screening if they do, maybe having more awareness from their healthcare provider team. This is somebody that we should be following closely. And patients just feeling more knowledgeable about their risk. There are also some things to consider for genetic testing. For some people, it might increase their risk or their levels of stress. They might learn from genetic testing that there's some other gene that causes a type of cancer that hasn't been seen in the family, but now they have an increased risk for this other type of cancer that they weren't expecting. Or like I said, some of these results might have a bit of a gray zone attached to it. We might not fully understand what those cancer risks are, or there might not be a clear set of screening guidelines based on that result. With all tests, there can be some limitations and a negative test result. So if you do get a normal result, and if we don't know what caused the pancreatic cancer in your family, it does not reduce your risk for developing pancreatic cancer. We still have to use your family history as a guide. So you might be in that mild or slightly elevated risk because you have a family history. In Canada and certainly in the United States, there's similar legislation where we do have a law that protects people from discrimination based on their genetic test results. And so that's certainly a positive thing. And reduces some of the barriers there. I have a quick video I could show you maybe at some point. It's about 3 minutes, and we just started this video approach so that patients get a very short and condensed set of information about genetic testing. It's also on our website at BC Cancer. I do want to kind of leave everyone with that kind of sense of steps that we can take to reduce our risk for pancreatic cancer. And certainly the key one is to be a non-smoker. Smoking is thought to cause approximately 1/3 of all pancreatic cancers. So if you wiped out smoking, you would be wiping out a good number of pancreatic cancers. Maintaining a healthy body weight, limiting alcohol, being physically active, and of course, diet. So focusing on a healthy diet. Something that's kind of maybe a newer point that I'm making with my patients is to consider screening for type 2 diabetes. And, studies have shown that new onset diabetes, especially in the setting of weight loss, is an important clue for pancreatic cancer. So if somebody was to develop type 2 diabetes, especially again, in that weight loss scenario, it should prompt close follow-up and kind of surveillance imaging of the pancreas and looking at maybe some other markers that your doctor could do for you. I'm mentioning this PROCEED consortium. BC Cancer is part of it. There are Ontario and Quebec have genetics clinics that have joined it as well. And this is a consortium that's going to follow individuals who are at increased risk for pancreatic cancer, who are undergoing annual screening, to really try and evaluate how effective that screening is and whether there are new biomarkers that could help with early detection. So blood, urine, serum markers to kind of look at a combination approach that might be helpful in increasing the sensitivity of screening. Take-home messages. I think that the key ones we've really covered. Genetic testing is available. That's my main point for everyone here. And in about 5 to 10% of patients, it can change medical management and help you get tailored screening. Having a mutation does not mean that you'll develop cancer. So really important to remember these are cancer susceptibilities. We need other risk factors to accumulate before that jar would fill up and before we would actually develop cancer. And some individuals with hereditary cancer syndromes don't develop cancer during their lifetime. Screening for pancreatic cancer is available. It should be carefully discussed for patients that meet that risk threshold of greater than a 5% lifetime risk. And important that it be done at a place that has a lot of experience. You could speak to a specialist about that. And of course, staying up to date on the newest research for pancreatic screening and biomarkers with groups like Craig's Cause and other groups as well. All right, I am going to stop there, and I think it's good timing for maybe a few other questions or any thoughts or comments.
Yeah, we do have some questions in the chat. Thank you so much, Carol. That presentation was fantastic. We've got a few questions here in the chat. Let's see here. So my siblings and I all tested with color.com and we're pleased with their service. Color offered us a steep discount because our brother had a pathogenic ATM mutation. We all tested positive for the same mutation. To access our results, we had to set up a phone consultation with a genetic counselor from color.com. Also, doctors at color.com will provide the authorization based on medical and family history, so you don't need your doctor's prescription. I live in the US, but I contacted a first cousin once removed about testing. He used color.com as well. Thankfully, he was negative. Finally, we all knew that we should have our life insurance, disability insurance, and long-term care insurance in place before testing. In the US, we could have issues getting those types of insurance if a mutation or concern turned up. And then she said, how often do the genetic testing panels get updated? My question is sort of related to which I can read after this. So for example, if someone was tested in 2016 and was negative for pathogenic mutations, were there genes of concern that were not included in the panels back then? And was wondering, I had genetic testing done and it was negative. Since I had both pancreatic and prostate cancer, could something still be there? What should I tell my 25 and 23-year-old daughter they should do as they get older? I was 44 when I was diagnosed with prostate cancer and 52 when I was diagnosed with pancreatic cancer.
Those are such great questions. And yes, absolutely. Genetic testing has evolved. It has changed even in the past 3 or 4 years. And so what it comes down to is knowing what you were tested for. I think it's so important for patients to get a copy of that report. Color.com or Color, COLOR.com, that's one company, and we've used them before in our clinic. Ambry Genetics is another one. Invitae is another company. All of these companies can give patients, or your genetic counselor can give you a copy of your report. And it's important that it does cover all of the key pancreatic cancer genes. So without knowing the exact genes you were tested for, I think this presentation has shown you kind of the current pancreatic cancer genes, so making sure ATM was on it, for example, PALB2, those are kind of the key ones, CDKN2A, some of the genes you learned about today. But I'd say since around that year, 2016, most labs would be looking at kind of the multi gene panel approach for pancreatic cancer. Where I'd be more concerned is if somebody said I had testing for 2 genes that cause hereditary pancreatic cancer and I'm negative. Is this good news for my family, for my kids? And then I would say it'd probably be best to consider an updated test. Again, ideally in the person with pancreatic cancer, if they are available, just to see if it might be one of those other genes, like ATM or PALB2, which are a little bit more recently kind of known for their association with pancreatic cancer. But generally speaking, probably every 2 years, you could check back with a genetics clinic or a lab to say, is there anything new in terms of testing.
Yeah, we do have another question here. I'm 34 years old. Is it possible to have genetic adenocarcinoma, ductal pancreatic cancer if in my family nobody has this type of cancer? Only my grandfather had prostate cancer at 70 years old.
Yeah, so it sounds like you don't have a family history of pancreatic cancer. You're otherwise a healthy 34-year-old. You're likely not at any increased risk compared to average for pancreatic cancer. And you're likely to having a hereditary cancer syndrome is probably low. It's not zero. We've learned that from just, testing so many people over the past few years, but it probably wouldn't meet criteria for most guidelines for funded testing. Prostate cancer is something to keep an eye on. 1 in 8 men will develop prostate cancer. But in men with a metastatic or more aggressive kind of prostate cancer, we believe that 10% of those patients could have a hereditary risk factor. So, certainly if there's a strong family history of prostate cancer or metastatic prostate cancer, those patients are now generally being offered genetic testing just to see if they fall into that hereditary cause for their prostate cancer. So that might be the one thing I'd say to keep in mind, given that you have a family history of prostate cancer. But it doesn't sound like the family history is as striking as it might be for some families. I think an important thing to keep in mind is just our own personal risk factors as well. Some ethnic backgrounds have a higher risk. So for individuals who have Ashkenazi Jewish ancestry, even if they don't have a family history of pancreatic cancer, genetic testing might still be helpful because there are a few what we call founder mutations in BRCA1 and BRCA2 that are more common in that population. So I'd say that would be an exception where even if you don't have a family history, you would likely be eligible for genetic testing.
Just wondering, does Alberta offer gene testing?
Yep. Alberta has a hereditary cancer clinic in Calgary and in Edmonton. And if you go to that CAGC.ca website and you look for search for a clinic, both of those locations will come up, and they do have pretty comprehensive genetic testing. So I think that's a great option if you live in Alberta. For everyone else on the call today, so there are, we only briefly touched on a condition called hereditary pancreatitis, but it's kind of inflammation of the pancreas, which can lead to scarring and tissue damage, and that in of itself can increase the risk for pancreatic cancer to form in the pancreas. Chronic pancreatitis can be because of excessive alcoholism, and so damage the pancreas that way, but it can also be because of an inherited genetic risk factor. And so SPINK1 probably wouldn't be tested for most people who have a family history of pancreatic cancer unless there were episodes of this diagnosis of a chronic condition of pancreatitis. And it's still a bit challenging to know what to do with that SPINK1 result. We don't know what the risk of pancreatic cancer is going to be for somebody with a SPINK1 hereditary finding. And it probably depends on whether their pancreas looks like it has any pancreatitis. There are a lot of people out there that probably have SPINK1 genetic variants. It's actually more common in certain groups and ethnic groups who would have a completely normal looking pancreas, presumably. And so it's a bit challenging to know, how to manage some of these results. But I think it's really still informative and interesting that, your mom did have kind of those key hereditary cancer syndromes looked at. And that was really important because those ones are ones where we have conclusive evidence about, a particular cancer risk range and management guidelines to recommend. And so, although your mom didn't have one of those straightforward scenarios, this pancreatitis gene, we're learning more about those and how to manage people with them. And I think it's great that you were able to access that commercial testing. Invitae is another lab that has that medical grade multi-gene kind of panel. So that's great.
Fantastic. Sorry, I know we're a little bit over time. Carol, are you okay for one more question?
Absolutely. Yep.
Awesome. Okay, so I guess it's not really a question, it's more just a bit of a story. I don't know if you'll have anything
Sure.
add to it. We were very surprised at our pathogenic ATM mutation. No recent family history of cancer at all in our family, but looking back, our paternal great-grandfather had it and died of it in 1951. That line of family is very small, and my dad died young at 49 before a cancer might show up. So don't assume you don't have a hereditary mutation based on recent family history.
Yeah, super good point. And it's kind of, I thought it was such a great move in 2019 by the National Comprehensive Cancer Network to just say everybody with pancreatic cancer should be getting this test, because for many of us, we might not know all the details about our family history. There might be, it might not be discussed as much, or might be gaps in our knowledge. So completely agree. I think that's a great example.
Excellent. Well, thank you so much, Carol, for coming out today. We really enjoyed your presentation and learned a lot, and very excited with all the information that we have. So thank you so much. I'll be staying on the call if anybody has any questions or anything that they want to ask or need any support or anything. I'll just be staying on until everybody's gone. But yeah, just wanted to thank you again, Carol, so much. It was a great presentation.
Great. Thank you so much. Nice to meet everyone, and all the best.